Okay. Hi, everyone. Welcome back to another, I would say, series for my Swallow Talk. Today I have I'm actually very delighted to be joined by Dr. Anadee Nikte. She's an occupational therapist and a healthcare leader with more than 15 years of clinical and leadership experience across post-acute care and rehabilitation settings. Dr. Nikte earned her Doctor of Occupational Therapy degree from University of Utah and have served in a variety of leadership roles throughout her career, including being a director of rehabilitation, senior director, and currently as a program director for an acute rehabilitation unit with LifePoint Health. In her current role, she helps lead interdisciplinary rehabilitation programs focused on providing intensive therapy services to patients recovering from stroke, from neurological conditions, and other complex medical diagnoses. In addition to her clinical and leadership contributions, Dr. Nikte is an educator and a presenter who has shared her expertise at professional conferences. Most recently, she presented on promoting the value of occupational therapy services under the patient driven payment model, the PDPM, at the Occupational Therapy Association annual conference. Beyond her impressive professional accomplishments, I would add this, Dr. Nikte, that I had a privilege of knowing you for many years now. In fact, when I first moved from I think Los Angeles to Bay
Right.
Area,
Yeah.
it was one of my only one facility, like actually the first facility where I worked with you, Alameda Healthcare and Wellness Center.
Yes.
Yeah, that's where I had the opportunity to have you. You were my director of rehab, and oh God, I didn't know anything about what was that? Rehab Optima. Now it's called Net Health because because I knew all about Kasamba, and oh God, it was quite a journey.
I guess time flies. Yes, it's been decade, at
It's
least a
been a
decade.
decade.
So
Yeah. Oh my goodness, that's right. Well, I just wanted to also say that over the years, I've seen firsthand your dedication to patient care, patient-centered care in terms of interdisciplinary collaboration, advocacy for individuals recovering from stroke and other neurological injuries. So, with that all being said, we will be discussing the role of occupational therapy in dysphagia management, also stroke recovery, life after discharge, and the importance of collaborations between OT and SLPs. So, Dr. Nikte, once again, thank you so much for joining us today, and we are excited to have you on Swallow Talk series.
happy to be here.
Thanks. So let's see. So let's focus on the main content. Like SLPs often focus on swallow physiology, while occupational therapists always focus on functional eating. So how do you differentiate feeding difficulties from swallowing difficulties when you do when our roles overlap?
First of all, thank you for that great introduction, Dr. Sonal, and happy to be here.
Thanks.
Taking your first question, and it's a very intensive and a heavy question, I think, and that goes across all spectrums of rehabilitation, whether it's acute care, whether it's post acute care, whether it's outpatient therapy, and even long term care for that matter, is like how do we really assess, identify for swallowing and feeding disorders, and dysphagia is a very big thing in general for people or patients in all spectrum of these setting. To your point, you being a speech therapist, you guys are focusing so much on swallowing, the anatomy, the physiology, and what it entails into a swallow. But as an occupational therapy, we focus on the occupation of eating, the occupation of feeding, and you cannot separate one thing from another. We cannot have a safe feeding or a safe eating practice without the safe swallowing. We don't want the food to go into the wrong pipe, and then it's like, what's the point of that occupation? So, to put it in words, it is a very integral part both for occupational therapy as well as for speech therapy. But from occupational therapy, we are focusing more on the deficits, but also the entire occupation of feeding or eating. So whether it is how are you positioned to be able to feed yourself, how is your upper extremity strength to be able to bring that food from table to mouth, what is your strength in terms of your fine motor coordination to be able to navigate the utensils that you're working, to be able to open up your plate or containers. How are you able to see the food? Are you having a visual perceptual deficits that you're having a hard time being able to navigate what kind of food is on the table? And not just that, I feel as an OT, we look at feeding from an external perspective, but even in terms of cognitive, are we able to follow the instructions that are being able to set by the speech therapist to be able to swallow the food safely? Are they have enough attention span to be able to intake the amount of food, or even hydration for that matter? When we talk about feeding and swallowing, it's all, the solids and the liquids. So entailed into a big spectrum of being able to navigate that entire occupation of self-feeding or eating. And this is where my paths have crossed with, a speech therapist as a newer clinician, newer occupational therapist. This is the first time, out of the clinic or out of the school setting, when you get exposure to how feeding takes place in context of acute care setting or in post-acute care setting, and how as OTs we collaborate or work closely with speech therapy. And we don't really focus on just, okay, the eating, but again, the dysphagia in terms of what is going to help patients to be able to have swallow safely, but also make sure they have good intake for their nutrition.
That's true. That's really good. Yeah. That's why I mentioned about the functional eating. Because there is I'm just gonna go ahead and say it, that there is a big myth that feeding and swallowing are the same thing. But when in reality, as you mentioned, feeding is much more broader, where it includes positioning, attention, the setup. Mostly you have to have a
Right.
setup in terms of the utensils to be placed on the table, and then the pacing, because with limited endurance or other environmental factors, let's say stroke with one-sided weakness,
Right.
yeah. So there's so much more that goes into the occupational side of it, and how that's where I love to collaborate, and I wish I would say I could more do co-treats with OT, but I think that's a really beautiful area that where interdisciplinary alignment comes in. So actually, that also puts me on to another. It's a similar question about the interprofessional collaboration. What does exceptional collaboration between occupational therapy and speech language pathologists look like, particularly when caring patients with dysphagia?
Yeah, that's a great question. And this is, I think, a question worth, thousands of dollars of knowledge, because I feel like this question gets highlighted between, again, all settings, whether it's acute care, whether it is post acute care or outpatient, is how well can you have patient safely perform swallowing within the spectrum of care. As I was saying, my first exposure to the whole concept of feeding and swallowing is when, as a new clinician, I was doing a co-treat with a speech therapist, and I saw how intricate it has to be in terms of balancing what speech therapist is doing and what an OT is doing. In terms of the interdisciplinary collaboration, I think it is very crucial when both, as a speech therapist, when you're giving a recommendation on the diet, on the texture, on strategies that you want the patient to use, and how that can be communicated to an occupational therapist and to the nurses, and vice versa. As an occupational therapist, when you are recommending feeding devices or equipments or adaptive equipment for self-feeding, when you're making recommendation on positioning, when you're making recommendation on visual perceptual deficit and what strategies are going to help, that needs to be again communicated both to speech therapists, to the nursing team, also even family members, depending on what setting you're treating dysphagia. And ultimately your doctor is the one should be involved in this case, your nutrition team. All of this kind of falls within the spectrum of how we can provide safe swallow, safe feeding for that patient to help maintain their nutritional needs without the severe risk for aspiration, because again the ultimate goal both for swallowing, for dysphagia and feeding, is to have a really safe swallow. So it works best when the teams collaborate. And I've learned this, even the harder way, that when as an OT I know my patients are not meeting my goals, is there a lack of collaboration between the speech therapist, in terms of nursing, am I not communicating with nursing, like what would be the best posture, a postural device to have them upright for that safe swallow strategies if they have underlying dysphagia. So it is a key, I guess, for successful swallow for the patients is to have an interdisciplinary collaboration.
That's beautifully said. I think the points that you brought is beyond the rehab, by bringing in the registered dietitian, by bringing the registered nurse into the picture. So, everybody is on the same page. And also, like you mentioned, I would just, there's another myth about, oversimplification, like if I could say that if a patient is cleared to eat and it's like, oh, the speech language pathologist has cleared the patient to eat and he can have POs. But that doesn't really mean that they are safe, despite of, let's say we put patients on oral diets, but as you mentioned, the positioning, the cognition, the neglect, the visual neglect, and overall, and also I think the fatigue really plays a vital role, because patient can have pneumonia if they are just like slouched and they are not in an upright position. So I
And we
think
see it often where patients are like, oh, they can eat, 25% of their meal by themselves, and then they are so tired, and then somebody either has to feed them, or either, they're not able to maintain their swallowing strategies of chin tuck, or, alternating between solids and liquids. All of that needs a little bit better collaboration. And oftentimes, in such severe cases, we do involve our nutrition team, because it's like you're doing calorie counting, you're making sure that they're getting the intake, because then we don't want things to go down the path where again they are having discussions about tube feeding and whatnot, and even as um, a therapist, we it's hard to see clients on an alternative diet. The goal is to have the least restrictive diet so that they can fully enjoy the meal. And as individuals, food is so close to everybody. We want to have food that
yes.
we enjoy eating. Food has social connections. So when you're looking at feeding and swallowing in terms of dysphagia management, the least restrictive diet, food that people can enjoy. And even at times, the one thing that I've noticed with the interdisciplinary team is even cultural preferences. At times there are cultures, who prefer certain kind of meals. American meal may not be the most liked meal, and they want to
Yes.
eat something that is more comforting when they're healing from an injury or being in the hospital. And we have to take into considerations those things as well, what can be the safest things. And even between the OT and between the speech therapist, I think we've always had that discussions to, oh, family or patient prefers this kind of food, and what can we do to provide that safest texture, so there are no risk or complications from dysphagia.
I love that. Beautiful, the cultural aspect and optimizing hydration and nutritional needs. Um, So let's move on, Anadi. I would love to hear more about, sorry, Dr. Nikte. You work in acute rehab unit. I just absolutely love because that particular settings, especially patients who have neurological deficits, they can actually get their 3 hours of treatment, and each and every discipline can actually cater to the needs of the patient and tailor all the goals as per what the patient would want. So many stroke survivors leave acute rehab while still facing significant challenges. What are the biggest gaps you see in recovery once patients return home?
A very good question in terms of, and again, pertaining specifically to stroke rehab and dysphagia management, is what I have seen is the continuum of care and being able to get to the next level of the care in a timely manner. An example
Mm.
would be, when we work with patients who get 3 hours of therapy, we are working on their swallow strategies, we are working on their cognition, related to the stroke. They're recovering with us. Our goal is to advance diet and, get them to the optimal amount of diet. But again, every stroke is different. Every impact of stroke into their dysphagia can be different from, as you know, from severe to mild. And if it is mild to moderate, we've seen outcomes can be achieved in like good 1 to 2 weeks, where we are advancing them with diet. Our speech therapy team is getting them to the optimal diet. But oftentimes, as a program manager, like my biggest challenge when it comes to dysphagia is patients with severe dysphagia who have potential to improve, but they need continued therapy. And then within the 3 week time frame, yes, we get a repeat MBS, we get them onto a diet. But again, everybody wants to eat the least restrictive diet. So when they are on their modified diet, the lack of resources in the community for dysphagia management, whether it is with home health or outpatient, and how soon they can get access to those services, is definitely a biggest gap. So a lot of what we focus on is training the patient and the family members into like, what are the safe options you can have, what are the other alternatives you can have. Oftentimes there are patients that would even call our speech therapy team and would be like, I haven't seen, a home health yet, speech therapist, unfortunately. And that happens, with staffing, or I haven't had an appointment in outpatient. So what can I do to, upgrade myself, or I'm doing okay. And all of that is in the bigger context of how do you provide a continuum of care with related to stroke and dysphagia management in patients transitioning from acute rehab back into the community or into their home environment.
That's right. That's, I think, outpatient scheduling can be really hard. It can be very difficult, and I think so on and so forth. It also goes into the home health settings because it's always not easy with so many other variables. But that can be a totally different topic for another.
Absolutely, yeah.
It's systemic errors. It's there's so much more we can do. But I really liked one point that you mentioned about the caregiver training because and obviously more in terms of being a program manager, from that perspective. But what I personally see a lot is the caregiver burden and their readiness, and there's a gap that when they see that every day my family member is getting treated, and oh my goodness, how will I do that if I go home? So it could be feeding assistant, it could be recognizing aspiration science. I would talk more about the dysphagia side, safe positioning. So I think that really puts caregivers also in a lot of, they're more nervous and they're not really sure if they would be really ready. So having that caregiver training getting done and completed, I think that really aids to a lot of help that the caregivers would feel that, at least I got some training with
No, absolutely. And part of the caregiver training, I would say, starts pretty early on in their admission to acute inpatient rehab. Like we don't try to wait until last minute, depending on how patients are, presenting and progressing. I think positioning can help throughout their course as their dysphagia is getting better. So, like training in positioning, training in being able to identify the signs and symptoms of dysphagia early on, and training them in the right way. The caregivers, nobody really comes with the knowledge for assessing dysphagia or aspiration risk, so getting those caregivers trained on some of those certain sign early on. There are few handful of community resources that we use as well. That there are some YouTube videos that focuses on caregiver training or just understanding from a layman's perspective of what to observe in terms of dysphagia. Like some of those basic educational trainings have been very helpful for our caregivers and our family member, and then bringing them on into if they are needing specific diet or modification, is like the speech therapist and the OTs are really working with them, from starting on how to make those textures, how to make sure that you're balancing the ingredients right, and if it's a cultural preferences, like how can some of those cultural food and recipes be modified to manage those needs, in terms of training. And then again, from OT perspective, like equipments, what kind of if attention is impaired, like how are you going to help them to be there and pace those clients? How are you going to help with fatigue, breaking the task down so they get their meal at a certain time? So all of those are considered, and a big aspect of caregiver training in terms of family needs. And we try to train multiple people. It can get overwhelming if it's just one person as a caregiver managing all
Yes.
that, but still sometimes you work with limited family support and
Yes.
aspect to who get this person trained.
Yeah, absolutely. That's why I think that the discharge process is so critical. From a medical standpoint, it could be different, but when it comes to the rehab, the overall functioning, from the human standpoint, I think
Right.
it's more robust, and you have to really factor into a lot of other areas before kind of saying that, okay, it's a safe discharge, and we can go ahead with that. So.
Absolutely.
Yeah, so that brings me to this question. What inspired you to create Rehab Connect, and what unmet needs were you hoping to address for stroke survivors and other caregivers?
Yeah, thank you for bringing up this question. So, Rehab Connect is definitely very personal to me. As a clinician, a healthcare manager, and a very recent spinal stroke survivor, when I went through this whole process of, recovering, or I guess I'm still recovering from a stroke myself, it just opened completely new doors to understanding when you embody being a patient going through a healthcare system of meeting with physicians, the rehab, the discharge, and then transitioning back home. I often tell my patients, and this was even before I went through my own journey, is like rehab doesn't really stop when you get out of the hospital. It continues. And again, as a stroke survivor, it is something that is lifelong process, and that's the biggest gap that I noticed, which inspired me to create a Rehab Connect. I feel as a clinician, I definitely wore a very different hat and looked at things from the perspective of like, oh, what are the physical needs, what are the occupational therapy needs, or what are, even in terms of what are the swallow and cognitive needs, to help them be independent with some of the self-care tasks or help them get into the community. But when you embody being a stroke client or stroke survivor, you are at a cusp of how do you integrate all of your physical impairments, your motor impairments, your neuro impairments, your swallow impairments into a life that you're still trying to live. How do you navigate being able to go back to work? How do you navigate your fatigue? How do you take into consideration your emotional aspect of it, your social connections? And I noticed that most of the times our focus was only on, okay, getting you from the hospital to home. But then what happens after home? The care coordination, either it is delayed due to staffing reason, or you don't have access to it right away due to limited resources or whatnot. And how do you navigate that recovery or that progress into the next phase of your life? And again, I am a young stroke survivor. Oftentimes we work with patients, who are in their 20s, 30s, and trying to get back into everything. So I saw that there is a huge gap, which helped me focus on creating resources that focuses on what's available in the community for them other than just generic therapy options. What other things we can do so that they can be motivated, so they can navigate their transition from the hospital into real life setting, into the community, into the home environment. So this has been my passion since my stroke, and I've planned to focus on building it, focus on working with my community itself, and kind of expanding into those resources.
That's amazing. No, I think uh, resources and programs like Rehab Connect, I think our community really needs that. As you mentioned, that outpatient can be so limiting. There could also be home health or any other resources could be so, or settings rather. At least we have something to fall back on where patients at least feel that even just like a phone call or talking to a therapist who knows like the robust overall holistic picture about what stroke rehabilitation is versus just more like physical therapy, occupational or speech as your it's overall, it's the whole thing that helps patients to understand that, okay, there's somebody with me that I can call and talk about things, and it would be helpful. So uh, I'm really thrilled for Rehab Connect and getting started with such a beautiful program.
Yeah, and absolutely. I think, because of my having a clinical lens, having a program management lens, and now as a survivor lens, like all three different lenses have really helped me spearhead this project. And I feel like this project is going to evolve in the upcoming years to really understand how I can better support the community, especially community where people really don't have resources and really don't know how to navigate our complex system. And that's one thing that was very apparent through this transition is people who have resources are able to navigate some of things a little bit easily, but those who don't are the ones who are struggling and are living with lifelong disability. So how do you connect the dots and the gaps in these resources to people who really need it and who don't know where to look for them?
Right. No, I think as you mentioned, like being a clinician or being a healthcare provider, I think it's totally different when you're on the other side being a patient. And, as you said, stroke is like being in the field, you kind of know what could be the repercussions, what could be the effects of it. So I think balancing this whole process of healing, I think I'm sure it must have been really hard, but I'm glad the whole rehab part and everything worked out, and it led you to this beautiful beginning of Rehab Connect. So I think it would be spectacular and phenomenal for others as well. Also, I have This question, it's a burning question because also, as you mentioned about stroke survivor, if you could change one thing about stroke rehabilitation tomorrow, what do you think it would be and why?
Yeah, I feel like as wearing all three hats, as a clinician, as a healthcare manager, even as a stroke survivor, I think the biggest thing that I would change or shift in stroke recovery and stroke rehab is transitioning from just an episodic care model where we are just looking at the stroke as in itself at that point versus how can we create a program that supports this population for a lifelong recovery and a lifelong journey. I mean, we all know every stroke is different. Impairments from stroke can be drastic, from
Yes.
somebody just having mild dysarthria to somebody having, complete one-sided weakness, severe dysphagia, severe cognitive deficits. And when people don't get access to extensive therapy. I mean, we all know that for neurorehabilitation, the key is to have repetition and intensive therapy and neuro recovery. And
Discipline.
we don't have that access, then that impedes their progress and their ability to recover and heal doesn't stop when they walk out of the hospital or they walk out of the rehab building. It is in some cases, years or even a lifelong aspect. I mean, just from my experience, my body is not what it used to be. It's never going to be before this, and it's going to be in a very different phase, and I have to learn to constantly adapt. One thing I thought about, like, oh, this year my goal is going to be able to walk x amount of miles or to be able to run again because I enjoy running and I enjoy hiking, and I'm like halfway in this year and I'm like, those were, yes, my goals, but I'm still doing so much. I am picking up my kids after school. I'm doing
Wow.
a 8 to 5 job as a program director. I'm dropping off my kids, and all those progresses you cannot measure in terms of a goal that you have or you didn't have. Stroke recovery is a lifelong journey, and then transitioning our healthcare system to really look at it from a holistic perspective is what I'm really trying to achieve, both through my program, but also as a healthcare leader in this industry.
No, that's true. I just want to say that I I have a lot of respect for you. Being a mother, I don't think it's talked about enough how demanding it is to raise a family while also being fully present and accountable at work, especially in our field where uh, literally there is no much room for error. So balancing both roles is honestly phenomenal. I tell this to everybody, all my colleagues who have kids. And I have a deep admiration for that. And even though I often feel like you're barely able to kind of how do I say, like, draw that line that, okay, even picking up, like you mentioned, your kids or having, it's a part of, building endurance. It's functional endurance that you're building. And also, like, staying in meetings, let's say for 2 hours, 4 hours, one after the other. So the cognitive overload is also there. So I think when we talk about work, we all are actually present. Program managers are always have to be be there, be lively, be in the moment, be present. You can't just like, okay, I'm going to like check off right now for like 2 minutes. And then the case management meeting is going on. And it's like, excuse me, what was it? So yeah. I
Right.
totally it's what I'm trying to say, it's intense work, but also yet it's very rewarding. As we know, we our patients need us, and the neuro component significantly impact so differently for different patients. Even a mild dysarthria can be really devastating for patients who
Exactly.
he's a let's say he's into management and he's in leadership and he has to give presentations. His role, his entire job would get completely impacted. So we understand how it can really translates to the deficits can translate to how impactful it can be.
Yeah, and we all know, like, stroke disability related to stroke can be so varied, both the seen aspect of it when you're having, yes, the physical impairments, but also the unseen aspect of stroke disability. To your point, what you were talking about, just your own confidence and morale, if you cannot speak confidently, the emotional burden of it, the cognitive fatigue, which nobody can really see, the physical fatigue that nobody can really see, and how do you navigate your personal life. And every stroke survivor is at a different phase, whether they're a young stroke survivor or in their older age, things that they like to do, and how do you navigate and do those hobbies and engage in life in a continuing momentum are big challenges in with stroke recovery.
Right, absolutely. So, what this conversation reminds me is that behind every stroke diagnosis is a person, a family, and an entire life that changes in an instant. Our role is not just to treat impairments, but to help people reclaim function, their identity, and hope in the aftermath. And that requires collaboration, compassion, and seeing beyond the hospital walls. Like what Dr. Nikte rightly said, that the actual rehabilitation just doesn't stop when you get discharged, but it actually happens once you leave those hospital walls. So, Dr. Nikte, thank you again so much for being here and giving us that perspective of what stroke rehab can overall look for different individual. And I wish you all the best for Rehab Connect.
Thank you so much. Appreciate you having me on this conversation, and appreciate all the good work that you're doing on, spreading knowledge and training caregivers with related to dysphagia, swallow, anything speech therapy related. So appreciate everything you're doing as well.
Thank you. Thank you so much.